Thank you very much for the invitation to speak for a few minutes. I'm sure everybody's probably getting a little bit hungry at this stage. So I am an advanced nurse practitioner in diabetes and integrated care in the Sligo-Leitrim area. And I suppose I was asked to speak for a few minutes just around, I suppose, my experience, and certainly I suppose I'm speaking from a nursing perspective around the auditing requirement. Which is super. But anyway, so I'll move these slides. There we go. So I'm sure everybody really on this webinar is very familiar with what is clinical audit, because we're all auditing different aspects of our practice. So the purpose of audit is to provide this quality improvement process that seeks to improve our patient care and outcomes through a review of our care against explicit criteria. So we're always measuring against a particular standard, and to introduce quality improvement mechanisms where the audit has identified maybe where standards are not being met. Why is it necessary? Well, I suppose certainly from our point of view, over the last number of years, our expanded nursing role to include prescribing, as I said, audit is an integral part of that, and as a regulatory requirement from our regulatory body in NIMBY, which is the Nursing and Midwifery Board of Ireland. It supports best practice because it makes us look reflectively back at what we're doing and ensuring that we're appropriately prescribing, and even as deprescribing in cases that's necessary. It offers openness and transparency because we often, it's recommended that we, and certainly in our department, do peer-reviewed audits. We're evaluating the safety and the clinical appropriateness of our prescribing. And as I said, it's a professional guidance requirement, and it's a HSE requirement to ensure that a mechanism to audit is in place. And we do locally here have our local nurse prescribing documentation. So before we audit, I suppose, is to agree what kind of criteria for audit and what is to be audited. So for example, while we audit the actual prescriptions written, but it's also whether a patient assessment is required, whether the medication appropriateness is demonstrated, equally as important as the actual written prescription. There are lots of evidence-based resources online on the HSE website, which have been updated over the years. Our national guideline for nurse and midwifery medicinal project prescribing in 2020, and practice standards and guidelines that has been produced in and updated in 2019. And to agree an audit tool. Now, there are a number of audit tools available online, but over the last few years, we have an agreed audit tool that I'm going to show you in a moment, that we use certainly for nurse prescribing, and I don't see why anybody who is also a prescriber on the call wouldn't be also able to use the same tool, because it actually just makes the whole process a lot more painless, I should say. The criterion for audit. So a statement of good practice to be audited based on the best evidence available. So obviously, as I said, we're measuring against a standard, but to make sure that the writing is legible, the correct name of the product, the correct dose, the correct route, and then, as I'll show you in a few moments, the level of achievement against the criterion that would be reasonable is expressed as a percentage. So each section of the audit is automatically calculated, and obviously we're trying to achieve 100% in each area. So the sample size, it also depends on, I suppose, sometimes when a nurse starts prescribing, the number of prescriptions might be quite low initially, but it often doesn't take very long for those to increase. So the sample size is generally either a total amount of 10 audits or 10% of the prescriptions written within the audit time period. if, for example, a nurse started prescribing and they had only 8 prescriptions written within that time period, then all of those 8 prescriptions would be included in the audit sample size. So the data analysis, so again, as I mentioned, are the criteria meeting the standards. So the standards are documented and we are measuring against that. And also, which is important, is built into it. So depending on the outcome of the audit, if there's areas to identified for improvement, there's a quality improvement section that needs to be completed, and an allocating of responsibility, whether it's the nurse prescriber or a nurse manager that does that, that is important, and within what sort of time frame. So locally, we have an agreement around local governance for nurse and midwifery prescribing. Most areas will probably have that in place. And that's not just in the hospital. We also have a nurse prescribing documentation and governance that supports nurse prescribers outside of the acute area. So for nurses who are prescribing, particularly in integrated care roles. Who will take responsibility for the audit? Generally, the nurse prescriber, but then the prescribing site coordinator, which each area has one, either in the acute or community, the assistant director of nursing or director of nursing, assistant director of midwifery or director of midwifery, a line manager, or the clinical audit department. The frequency of audit is determined by the when the nurse prescriber in particular qualifies having the educational component completed. So it is a requirement that every 3 months an audit needs to be conducted for the first 2 years, then it goes 6 monthly and then an annual audit after that. The results of that audit is fed back to the prescribing site coordinator or local drugs and therapeutics committee, and it's obviously stored in what used to be known as cuples here. But if, for example, our regulatory body, like for example HICWA, make obviously as part of their reviews, may come in and ask for demonstration of audits completed by the nurse prescribers within the department or within the organisation, that needs to be made available. And then there obviously is a process for providing feedback to the relevant personnel and committee where I mentioned. So initially, it is often recommended that the first person that might do the audit would be a self-audit, because I suppose when you audit, it kind of flags up things that you don't often realize. And I suppose one example, speaking personally, is that initially I hadn't even realized that when I'd started writing prescriptions, I would write, for example, a drug such as metformin, 500 milligrams BD for whatever period of time, assuming that everybody would have realized that metformin 500 milligrams prescribed BD would be deemed, or everybody would recognize that as an oral. So it's even sometimes the simple things that we just need to ensure that we are fulfilling all of the criteria for a prescription that I found myself initially doing. So that was one of the things that became very evident very quickly. So that was one of the first audits that I self-audit, as I said, that I conducted. Now, in terms of peer audits, usually that is what we conduct within our department. So all of, for example, the diabetes nurse specialists that work here are also nurse prescribers, and then we regularly do peer-reviewed audits on our prescriptions here. The prescribing site coordinator can undertake the audit. A nurse midwifery manager, as I mentioned, the clinical audit support staff or practice development facilitators, or even risk advisors, or sometimes a collaborating medical practitioner who's in the hospital is often a consultant relating to the specialty, or a pharmacist, or an identified member of the multidisciplinary team. As I mentioned earlier, the population and sampling, the audit population, all prescriptions in the selected time period need to be included in the audit population. And that's a random sample of 10 prescriptions within that time frame, or if there are fewer than 10 prescriptions written, all of those prescriptions written needs to be completed and be included in the audit population. So that would include prescriptions written for adjustments, for example, with inpatients or outpatients. So it's important that they are all made available to whoever is conducting the audit. I mentioned a little bit about the audit sample size and the data collection tool, and obviously then to go ahead and collect the data. So following that, then you're ensuring that the criteria, whether or not they're meeting the standards, some areas for improvement may be identified, and you're producing an audit report similar to an audit that you would be producing in other areas. Obviously, it will include the title of the audit, the background, the aims, standards, methodology, results, conclusion, and recommendations. So any quality improvements need to be highlighted where standards are not met, and identify the quality improvement opportunities that need to be introduced to ensure that the standard is met at the next audit when it is due within the appropriate time frame. So whether that's 3 monthly or 6 monthly or annually, evidence of completion, review date, and the outcome of that quality improvement plan. So I'm just going to show you quickly what is the audit tool. Oh, it's probably a little bit big on there. I wonder, can I make that a bit smaller? I think I can move it over here a little bit. Oh, so no, maybe not. Okay, I wonder, can I just minimize that a little bit? Okay, because on your screen, it's probably only cutting in some of it. If I show it that way. There we go. I wonder, is that a little bit better in terms of the viewing if I just bring it up that sort of way?
Yeah, that's much better, thank you.
That's better, as you can see the end. Okay, so the audit tool that we use is an Excel document. So you'll see initially across the top here, you've got audit 1, audit 2. That goes the whole way over to 10, because obviously for your 10 audited prescriptions. So if I scroll down here a little bit, on the bottom here, there are instructions on how to complete the audit, demographic details of the nurse prescriber and the auditor, the actual audit tool, which I've opened here. It generates an audit report and a quality improvement plan as part of it. So under the audit tool, a patient assessment physical examination may not always be necessary. So in this case, for example, if a physical examination is not necessary in the instance of the prescription that is being written, you would put 1 here. So 1 goes into whichever column. So 1 here goes into non-applicable, but it also equally needs to be followed by a comment to explain why a physical examination was not necessary for that particular prescription. Otherwise, if the medical history would be included here, relevant clinical details in terms of laboratory investigations, any medication interactions or contraindications, allergies, and the rationale for the prescribing of the drug. And that just means that if, for example, we're using the medical notes, that the 10 charts need to be pulled for those 10 patients, so that if it's a written examination or a clinical review of that patient, that needs to be available to the person that's conducting the audit. In our department, all of our patient reviews are done electronically, so it makes it a little bit easier for us. So just to kind of bear that in mind in terms of your medical records department. So the first section here really is around patient assessment. If I was to scroll down, I'll go down to the next one. And again, I should be able to bring that over here. So these are kind of the standards around writing the actual prescription, obviously in terms of it being legible, the medicinal product, the correct dose, the correct route, the frequency, the name, and the, so it's important in terms of your name that it is written the same as it would be for the Nursing and Midwifery Board of Ireland. So for example, if I was known as Tricia Murray in NIMBY, then that is the name that I need to include on my prescription, or the opposite way around. So that is important. Your NIMBY, your medical registration number, which, as I said, for nursing is the Nursing and Midwifery Board of Ireland, to use indelible ink, be dated, the full name of the patient, the address of the patient, and if the patient is under 12, the date of birth must be stated. I would probably tend to put the date of birth in just automatically anyway. So the next section goes down to medical appropriateness. So is the medicinal product appropriate for the condition, which is why you need the medical notes available for you when you're conducting the audit? Was there unnecessary duplication of medications? And is there a relevant follow-up plan recorded when the patient is going to be reviewed? The section underneath is around controlled drugs. That doesn't use, that obviously doesn't, it doesn't include my prescribing practice, but obviously there is particular criteria involved in prescribing of controlled substances, and that would need to be completed. And following that, when I bring you down onto the end of the Excel, the score is automatically calculated here. So obviously the numbers of 1, wherever they are, will be in each section, gets calculated into the total, depending whether yes or no answers or the non-applicable. It's signed by the auditor, and it automatically includes then into the exports into the audit report, and a quality improvement plan can be developed, as I mentioned, subsequently from that. So it just makes life a little bit easier having a tool like this. All of the documentation in terms of, for example, the guidance on clinical audit I've just put up there is available on the HSE website, and some of the tools that we would have used in the past and the current one should be available on there. But if not, I'm quite happy if anybody wants to get in contact with me for me to email the Excel auditing tool that we use, if you'd like to do that, but it should be available on the HSE website. I don't know if there's any questions around clinical audit. That was a very whistle-stop tour, really, around from a nurse prescribing point of view, how we conduct a medication audit. But I'm quite happy to take any questions.
Patricia, thank you so much for that really interesting tour, as you describe it, through clinical audit. I don't see any specific questions related to audit in the chat. So I think, as you said earlier, Patricia, I think everybody might be just beginning to consider it's lunchtime. And Colin, if it's okay, I'll just close the session.